heartburn, and more next on Call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Tonight we'll be focusing on the upper digestive or gastrointestinal system, essentially from your mouth to your small intestine and everything in between. Conditions and diseases of the esophagus, stomach, and the beginning of the small intestine called the duodenum or duodenum, either way works, either word works, can be complex. The diagnosis may require specialized testing, and treatment may even require more complex options. To learn more, stay tuned. But first, let's take a look at this week's Prairie Doc quiz question. Tonight, you have to choose the best answer. When reflux of stomach acid up into the lower part of the esophagus happens too often and for too many years, the tissue changes in the esophagus, resulting in more burning symptoms or less burning symptoms. Choose the best answer, more or less. Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We'll announce the answer and the winner at the end of the show. Remember, though, you have only 10 minutes to get your answer in, but anytime we can answer your medical questions. We answer them about the upper digestive system as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight from USD Sanford School of Medicine is Dr. Tim Ridgway. Thank you for joining us, Tim.
Thanks for having me again, Rick.
Tell us a little bit about your background. You're from the big city of what now?
I'm from an obscure little town called Ravinia, South Dakota.
Ravinia. Which is down near?
Between Wagner and Lake Andes, right by the Fort Randall Dam in Pickstown, South Dakota.
Okay, so there you are.
Usually people will
So you're a little town South Dakota guy.
I'm a small town South Dakota boy.
And you did med school?
I did my medical school at the University of South Dakota School of Medicine.
And then you went to?
I went to the Mayo Clinic and did my internal medicine and my gastroenterology training there.
Okay. And then you came back to South Dakota?
Came back to South Dakota, and I've kind of done a little bit of everything. I've had a full-time practice for a number of years. And then about 10 years ago, the medical school offered me a position. So now I still practice at the VA Medical Center doing endoscopy 3 days a week. But in addition, I still enjoy the medical school, functioning as an executive dean, the dean of faculty affairs, meaning I oversee all the faculty activities. But the funnest part is still being involved with students at every level, and it's very, very rewarding.
Yeah. And at the same time, this year you're the president of the
South Dakota State Medical Association.
So tell us a little bit about that.
You know, it's been a very, very busy year, but it's been a wonderful year. And as I was telling some of our undergrad students tonight before the show, the funnest part has been getting around the state and talking to the doctors. And you know this, and I know this, but I think our viewers need to know it. We have some wonderful people in the state of South Dakota.
We really do, don't we?
Taking care of our citizens, and they care. They care about their patients, they care about their communities, and they're wonderful role models for our students.
Yeah. So, well, we thank you for this. Now, when we talked about doing this show about a year ago or 6 months ago, we were going to have Christina Hill on the show. She unfortunately is on call, couldn't switch it. So we're just stuck with you.
They're stuck with us, you and I.
And I must say that that you're a handsome guy, but Christina Hill, Jensen, kind of takes the cake. She's a beautiful.
My son said that to me. He said, not that I don't like you, Dad, but where's Dr. Hill Jensen?
She is a beautiful lady, inside and out. You know what I mean?
Absolutely.
But we're going to talk mostly about the upper system. Now, tell us, what is a normal upper GI tract?
Well, I think for our viewers, if we go to the telestrator and we can just describe how it works when you swallow food, because I think that's a great example. So
you've got teeth there.
You've got teeth, and so the food bolus will enter, and it will hit the esophagus here. Now, what the esophagus is designed to do is simply to propel and allow the food, so it relaxes, and it allows the food to come into the stomach. Now that's when everything starts to happen. When food contracts and hits the stomach, you have acid-producing cells that kick in huge amounts of gastric acid, which aids in the digestion of food. The stomach is designed to basically just mix back and forth, back and forth. It just completely grinds this food into small 2 to 3 millimeter particles, which then empty into the duodenum, which is right here, and then the rest of the small intestine. Now, a key point, and we're going to talk about acid reflux tonight, once the food hits the stomach, you have muscles here, diaphragms, and you have an internal sphincter muscle called the lower esophageal sphincter. This muscle in normal conditions tightens. Why? So that acid that is produced in large quantities stays where it's supposed to. Acid was not designed to come into the esophagus. And when it does, that's what creates a lot of the issues that I suspect we're going to be talking about tonight, and frankly, maybe our viewers have questions about.
So when a person swallows, there's a combination of action that happens with the tongue and so on. Explain that a little
Yes, it's very complex, but the tongue basically propels food and allows the food to enter here. And then there's an airway here. Your breathing tube is here.
So you got to push.
So the breathing tube is here. This is a valve that helps to close off that breathing tube.
That's
so
the epiglottis. You see that flop on down, it closes off the breathing tube.
It flips it right here, and that means food can only enter
here,
the esophagus.
So now let's touch the screen good and hard with the green. Okay. So show us where that epiglottis is.
Right here.
Okay.
So when we swallow, it closes, it protects your breathing tube so that food only can go in the esophagus. But as we get older, or if you've had a stroke, or if you've had other neurologic conditions, sometimes that mechanism doesn't work well, and food can accidentally enter the breathing tube. And that's what we call aspiration. It doesn't like it, and we cough, we sputter, we choke, and sometimes it can even set up pneumonias as people go. So it's very complex. We chew with our teeth. The tongue is used to propel the food into the back, into what we call the hypopharyngeal region, which is here. And then it senses the food, the airway shuts tight, and the food enters the esophagus, where the esophagus then uses its relaxation capabilities to allow the food to enter into the stomach.
Right, so this esophagus, there's 3 different kinds of levels of esophagus. What kind of muscles are?
Well, yeah, that's correct. You know, we have something we call smooth muscle, which is in the lower part of the esophagus. And then up high, we have something called skeletal muscle. Now, the difference is, if you've got a muscle condition, certain muscle conditions, it can affect the skeletal muscle, which will give you swallowing problems. And appropriately trained individuals can recognize that. Whereas there are other conditions that affect the smooth muscle of the esophagus. A classic one is called scleroderma. And basically, scleroderma, and that's
down in here.
That's down in there. And that smooth muscle it just lays there. It does not propel food. This muscle we talked about right at the sphincter is relaxed, and so acid is allowed to freely go up into the esophagus. Plus, the esophagus can't clear it because it has no motor function, and these patients get horrible ulcerations of their esophagus. They get scarring and strictures of their esophagus.
The scleroderma.
It's miserable.
Okay. What about the propulsion of food down there? I mean, there's this toothpaste tube kind of a thing that happens.
That's a good way to put it. It's a toothpaste kind of a thing.
I swallow, it moves it down.
It moves it down. But there are certain conditions that will not allow that mechanism. Or as we get older, sometimes that mechanism gets a bit dysfunctional. And if you did an X-ray in that case, what you might see is, instead of a straight tube, you would see this kind of a picture in the esophagus, which basically, it just isn't coordinated well. And so sometimes as we get older, it can be a little more difficult to swallow food.
Yep, that corkscrewing
Corkscrew
or
Presbyesophagus.
presbyesophagus. It has nothing to do with Presbyterian Church or anything.
Not that I know.
But they call it presbyesophagus, meaning old esophagus, I think.
Correct.
We've got a question. This can lead into symptomatic. Woman from Aberdeen, as far as symptoms go, do you need to have indigestion to have reflux?
The answer is no. There are certain instances that people will not have indigestion. They will not describe to me classic heartburn. And yet they will come in, sometimes even bleeding. And we take a look into their esophagus, and it's horrible, ulcerated. With indigestion, what do we look for? Well, it's, as you're showing on the screen, gnawing or burning stomach pain, bloating, heartburn, which is a term that means something to a lot of different people, but it's basically a burning sensation anywhere in the chest where the esophagus lies.
Right.
Upset stomach or nausea. Burping can be very, very common, whether people have reflux or not. It's just kind of an independent thing. But the person from Aberdeen said, do you always have this burning sensation if you have acid reflux? The answer is no. People have different thresholds of sensitivity.
So they can have the reflux and no symptoms at all. So the indigestion, though, is a broad word.
Very broad. It does not just mean acid reflux.
I mean gallbladder disease.
Gallbladder. Anything in the upper intestinal tract, including the gallbladder, the pancreas, those organs. So it's a very, very broad term and very nonspecific. And so when we get asked questions about indigestion, I always ask patients, you tell me more, and I try to get more specific answers.
So one of the big questions back in the 70s was, I have a hiatal hernia, is what they would come with. But I said to them, many people who have a hiatal hernia have no heartburn, no reflux, no symptoms, no problem. And then there are people who have no hiatal hernia that have lots of trouble. Explain that for me.
That is exactly right. Hiatal hernias are very prevalent. I probably have one, you may have one. Is that a bad thing? The answer is no. So what is a hiatal hernia?
Yeah.
Well,
yeah, erase that and, okay.
Ordinarily, the two big respiratory muscles, the diaphragms, basically when we breathe in and out, that's what moves our chest up and down. They separate the stomach from the esophagus. But in a hiatal hernia, what happens is that part of the stomach is above the diaphragm. And so what can happen is, yeah, sometimes that leads to a loose muscle and more acid can come up. But many people will have this diaphragmatic hernia. It does not cause any symptoms. It does not cause reflux. It's normal. And so I always tell patients when we diagnose it, they say, do I need to do something about that? And the answer is most often not.
Now, is there any, let's say you had reflux with your hiatal hernia. Would you ever repair it by bringing it down?
I get asked that question a lot too. In most instances, the answer would be no. And the simple reason is we can control that acid reflux with lifestyle modification and medications, which are by and large very safe. If you have horrible reflux that cannot be controlled adequately with lifestyle and with medications, the answer is yes. You can do a surgical procedure where this part of the stomach is pulled back down below the diaphragms, and then the surgeon will do a wrap, we call it. A Nissen wrap is the most common, where part of the stomach is wrapped around this area to restore that tight muscle. It's an effective surgery in appropriately indicated patients, but most patients do not need it, and it is a big operation.
Right. And I've heard also that you know, when you do a good wrap and you keep the acid reflux from occurring, 50% in a year are going to have reflux again anyway.
Absolutely.
And you're going to still have them on
There
meds.
was a well-done VA study where we looked at, and it was 5 years out, and over 70% were back on medications. And so I always tell patients we want to be very, very careful. We want to help, but we don't want to rush to this, and then they come back a year later and say, Doc, I got the same symptoms again. And a lot of times we'll see that these wraps have slipped, and they're back up.
Right.
But on the other hand, I've had patients that they're miserable. They're absolutely miserable.
And they failed everything.
They failed everything, and those are very good candidates for this operation, and it's very successful when you do it in appropriately selected people.
All right. Now, some people ask about GERD, gastroesophageal reflux disease. How is that different, GERD, from, let's say, heartburn, or how do you define GERD?
Well, I always tell patients, they'll come in and tell me, it's my GERD. And I'll say, but you got it, because GERD means different things to different people. But gastroesophageal reflux basically means that contents are refluxing from the stomach into the esophagus. It can be a structural problem, such as a hiatal hernia. Sometimes you can have a bacterial infection, although it's uncommon in the United States, in more cities and developed areas. Nonetheless, that can be a cause as well. You can also have non-acid GERD, where stomach contents basically reflux into the esophagus. They're not acidic, but they're still
Going up there.
going up, and it's a large amount, and that can create a lot of trouble for people.
Well, if they have GERD when they're laying down at night, they'll inhale it,
Yes.
and end up with lung problems.
Yes, they can have pneumonias. We have found people come in with pneumonia repeatedly, and we don't understand why, and pretty soon you have to start looking and digging for a possible GERD etiology.
I've heard also vocal cord dysfunction because of GERD, and they end up with raspy voices, and you look at the vocal cords, of course, because you want to make sure that they don't have cancer.
That's exactly right.
But when they don't have cancer and it looks like it's been burned by stomach acid, you treat them with omeprazole or
Yes,
and they get better.
Usually when it's that type, you have to use a higher dose, because we've learned that the standard doses just usually don't control that. Yeah.
Okay. We can talk H. pylori too, and that was brought up. But one of the questions had to do with probiotics.
Oh, yes.
So if you looked at the causes of the treatments for GERD or for reflux, a lot of them is that it's going to be either an H2 blocker, which is a milder, faster treatment, or the proton pump inhibitors like Prilosec or omeprazole that are slower but much more powerful. But it takes away the acidity in the stomach, and therefore infections can occur, right? Pneumonias. What's the problem with long-term use of the acid treatment meds?
You know, proton pump inhibitors we've been using for years. And I always say that any medicine that you start on somebody, you have to weigh the benefit versus the risk.
Right.
Now, in patients that have rip-roaring ulcers and are massively symptomatic, clearly that benefit is there.
Right.
But we've also learned there are some consequences to proton pump inhibitor use. One of the more common ones we're seeing now, particularly in long-term care facilities, nursing homes, is a bad diarrhea caused by an agent called Clostridium difficile, or C. diff. And we also might see thinning of the bones as people get older. There's been reports of a bad rash that occurs that can be very difficult to deal with. And you can get overgrowth of bacteria, because by suppressing acid in the stomach, it sometimes can allow for an overgrowth of other types of bacteria that can potentially cause problems. Now, I don't want to frighten our viewers and say they have to get off their proton pump inhibitor because we talked about these side effects. They're relatively rare, but we're finding them more and more. I think the key point is making certain you need this drug, because we've estimated there may be, Rick, up to a third of people in this country that have been on these medicines for so long and they don't need them.
And it's also very hard to get off of them. I mean, it's sort of like, let's use the word heroin for tachyphylaxis. I mean, if you use heroin, you got to go higher dose, higher dose, higher dose. If you stop it, you have withdrawal. And I've heard that if you started a person who didn't have any problem whatsoever on Prilosec or omeprazole for a month, and then you stopped it, they would have withdrawal acidity.
Yeah, they can have a little bit rebound effect, and they'll get more acidity. So then they think, oh my gosh, my symptoms I have to have it. And you're right. And then it becomes a vicious cycle. And so I would encourage our viewers, if your doctor puts you on this medicine, great. But make certain you come back and ask how long you need it. do I still need this, doctor? Because sometimes it'll just be, here, let's try this, and pretty soon it's
stuck on you.
It's stuck.
But they say you have to taper off of with a 3-month period of time. So if you're going to, and your doctor says, okay, I would say, skip every third dose for a month, every other dose for a month.
Yeah.
Take a third dose.
Everybody has their own taper, and I think...
Do you taper faster?
I taper faster usually, but I also tell people, if you get symptoms back, then we slow down. And I always try to educate and warn them and say, if you get it back and just call in and say, I need this drug now, I've had problems. No, let's taper it down. Let's go slower, and usually you're successful. So I think the take-home point here is these are wonderful medicines. They have revolutionized how we treat acid reflux. But having said that, there are still people that frankly don't need them, and we need to be sure we get off them if you don't need them, because there are potential ramifications.
Huge take-home. Is it better to take H2 blockers like the Pepsid and the Ranitidine than the Prairie?
Actually, what we've learned is if you can respond to Pepsid or Ranitidine, great. The problem is...
Same story, isn't it?
A lot of people just don't respond as well because you suppress acid much better with the omeprazoles and Prairie.
Okay, and so before we take a break, we've got some things to talk about. We want to talk about H. pylori infections. We want to talk about infections in general there, and that C. difficile infection that we talked about earlier. We want to talk about different kinds of medicines, and then we also need to say before we go to the break, what is the indication for a EGD, an esophagogastroduodenoscopy?
Which I'm sure you'll explain to our viewers what it means. Many of them have probably had it, but this is something that's important too, because not everybody that comes in with upper digestive symptoms requires an EGD. I look for things such as alarm symptoms. Now, what you see there on the screen is, if you've got standard heartburn and it's been going on for a while, untreated, that might be an indication to take a look. If the symptoms leave, but then they keep coming back, that's a way to look. But the bigger thing that I look for are what I call alarm symptoms. One of them is age over 50, 55. Worse things can happen as we get older.
Cancer, you're talking cancer.
I'm talking cancer. Trouble swallowing. If food is sticking on you, that's an indication to take a look. If you're low on blood, if you're anemic. If the symptoms wake you up at night, I always tell patients, that's not normal. And if somebody tells me these are waking me up, that's real. Is there weight loss? Is there unplanned weight loss? So these alarm symptoms are what alarm me. And I will tend to want to look at somebody's upper GI tract sooner rather than later if I hear any of them.
And it's like falling off a log, for goodness sake. They use medicines that it's so easy, you don't remember the procedure, and there's no problem afterwards.
And it's very safe. And
it's a safe.
By and large, it's very safe. You see someone that's qualified to do it, and frankly, sometimes it can be very, very effective.
There we go. While we have a number of indicators that aid in the diagnosis, sometimes it's just best to go in and see what things look like.
Well, an EGD is actually an esophagogastroduodenoscopy, also known as an upper endoscopy, depending on who's talking about it. What it is we're looking at the esophagus, the stomach, and then the first portion of the small intestine. The reasons that we do an EGD are for multiple different things. One of them would be dysphagia, which is difficulty swallowing, like if you were feeling like something was getting stuck in your esophagus, whether it be up here, in the middle, or down lower, that would be a reason to do it. Some people who have reflux, and that reflux is tried to be treated with medications, but it just isn't getting controlled well. That would be another reason. Or pain. Pain in the upper abdomen is a reason. Pain in the esophagus. Sometimes when people are swallowing, they'll have pain when they do that. We can choose between doing radiology studies versus doing an EGD for those type of things. Sometimes we start with a radiology study, sometimes we start with an EGD, depending on what's more available. What we're looking for is we're looking for any evidence of inflammation. We're looking for any masses or polyps, things like that. We're looking for ulcerations or erosions. The reason that we do the EGD is because there's possibly going to be a change in management of what we're doing with the patient. So we may need to adjust medications, we may may need to try a different medication or add a different type of medication to the patient. The patient may ultimately need surgery depending on what we actually find, if there's a mass or something like that. Another reason we would do it sometimes is if a person is anemic and we don't know why, and they have an occult blood that is positive. That would be another reason. Dark stools, melena, that's also known as black tarry stools. That's indication that there's blood that has been digested, and so we would do an EGD for that as well. This is a pretty easy procedure to recover from. The one that we just did was a dilation. She has an esophageal stricture, which makes it difficult for her to swallow. We know that it's benign, and so we were able to dilate it today. She won't feel pain from that. If the patient does feel pain, that's something that we need to know about, because we need to investigate and make sure that there wasn't a perforation, which is one of the risks of doing a EGD, where there can be a tear in the lining of the esophagus, or in the stomach or in the small intestine. And so if a patient does have pain, we need to further evaluate at that point. When we have somebody who has something stuck in their esophagus, like a foreign body, if they have a stricture that they don't necessarily know about and they eat something and it gets lodged in there and we have to get it out, their risk for perforation does go up a lot at that point, but it's still pretty low.
Thank you for that, Dr. Wee. So the question I have is, what is the most dangerous of findings in that EGD that you would have?
Well, obviously, the worst scenario is you find a cancer, either of the esophagus. We even see it in the stomach, although not as commonly, and the duodenum is rare. But that's bad. The other thing that we'll see is active bleeding. Usually from an ulcer in the stomach or the duodenum. And that's when patients come in vomiting blood, or they'll be passing blood per rectum, although it's usually not bright red, it's black and tarry-like. But that is an emergency. That is something that you don't wait around for. You come in, you get seen, because we've learned that the sooner we can find these, we have actual treatments through that endoscope, right. Clips, we can burn, we can inject medicines that scar the vessel. We have a lot of techniques where in the past, and Rick, remember in the early days we learned about ulcer surgery and all the different kinds.
Think about all of the surgery
It's almost non-existent now, and it's because of medicines like proton pump inhibitors, but it's also because we can do so many things with the endoscope to stop that bleeding.
All right, that's very important. Let's just dive into the questions.
Sure.
73-year-old man from Madison, caller has been taking Nexium for 6 to 7 months. That Nexium is about the same as omeprazole. It's just an isomer of omeprazole and more expensive.
Rick. You know, the salespeople and the commercials will want to make you think that one of these is better than another. And quite honestly, they're in the same class of drug. They have little nuances. But when appropriately dosed and followed carefully, there's not a whole lot of difference.
So omeprazole and Nexium, which is desomeprazole, and then there's
lansoprazole, which is Prevacid, and so
they're all about the same.
Numerous.
And this person wants to know, he's been on Nexium for 6 to 7 months, wants to know if he can do something to get off of it.
Absolutely. I think a lot of it depends on why he was put on it. But we do know that, for example, if you had an EGD and they found ulcers in your esophagus and they put you on a medicine like Nexium and, oh my gosh, it's the best thing in the world, I am fixed, I feel great. We do know that if you get off the Nexium, there's about a 90% chance those ulcers are going to come back.
And that you're going to need to stay on it.
Exactly. But on the other hand, if he's on Nexium simply because he had some indigestion, some mild heartburn, and the doctor said, let's give this a try. Well, first of all, it's diagnostic, right? If you've got those symptoms and they respond to Nexium, and you have none of those other alarm symptoms we talked about, that's a pretty good sign that it's acid reflux. My goal then is to, A, find out if we can get him on a lower dose, or always put him on a trial of getting them off. Yeah. And one of two things is going to happen. You know, we taper, like you said, and some will do great. They may do great for a year or two, and then maybe they'll need it back. Great, no problem. You gave
Got
them
a
a
year.
holiday.
Yeah.
You bought a year. So my advice to the caller is talk to your doctor about your motivation to want to get off it, and work with your doctor to see if that can happen. It may be possible, but you may learn that, no, I need it, but that's still helpful, I think, in the long haul.
Right, and I like the idea of saying that omeprazole is equal to Nexium. Nexium tablet is basically 40 milligrams of omeprazole. And if you've tried 20 milligrams of omeprazole and 40 milligrams of Nexium, which is like 40 milligrams of omeprazole, then you can't compare them. You got to go to 40 milligrams of omeprazole.
And it's much cheaper, by the way.
Much cheaper for omeprazole.
Much cheaper.
A woman from Lake Norden, is there anything I can do besides surgery again to stop my acid reflux?
Well, there's a lot of things you can do.
Non-medicinal methods?
Non-medicinal methods. You know, I think that we underplay lifestyle modification, things that you can do that might help. For example, if you have a lot of acid reflux at night, then perhaps look at when you're eating. A lot of people will have a bedtime snack. Remember earlier when I said that the minute food hits the stomach, acid is produced? So if you have a snack at 8 at night and you go to bed at 9 or 10 o'clock, that is the peak time that acid is churning in your stomach, and that can reflux in your esophagus. So I tell people, try to limit your evening meal no later than 6 o'clock, and don't go to bed for at least 3 to 4 hours afterward. Small, frequent meals. The less food you put in your stomach, the less stress, the less amount of acid produced. That can be beneficial. Staying upright after you eat. That's a big one. What do we usually do after we've eaten dinner? Well, a lot of us go in, sit on the chair or the couch,
And then recline.
watch TV. And guess what? That is an absolute setup. Things like peppermint, chocolate, will relax that muscle we talked about, this muscle that's very active right here. Foods like peppermint and chocolate will help relax that muscle. There are medicines people are taking that can relax this muscle and lead to
make the reflux worse.
Exactly. So again, to the caller, I would say, look at all the things you're doing. Talk to your doctor, see if there's any changes you can make. Now, having said that, a lot of people will say, I've done all that, doctor. I'm still having trouble. Mm-hmm. And so, yes, you can do the surgery we talked about earlier, but there's also some newer methods coming out. One where the surgeon will put a row of magnets in around here to help tighten the muscle. The jury's still out on how long that will be effective or if it will be effective.
Okay. Wow, magnets.
Magnets.
And I like the idea of elevating the head of the bed and putting 4 or 5 inches, not a wedge.
Not a wedge.
But 4 or 5 inches of books under the head of the bed.
It's too simple.
It's too simple.
And sometimes we want to think that there's a huge magical technology out there when the simple things can
really
make a real difference. And alcohol, by the way, I forgot to mention that. Having that drink at night, I'll tell you what, that will relax that muscle and really lead to
bring on the reflux. Yeah. 68-year-old woman from Volga, could taking acid reflux medications increase the chance for dementia?
Oh, you know what? I thought we would get that question tonight. This is an informed caller because this just hit the news in the past couple weeks. There was a study performed where they looked at a large number of elderly patients that were on one of these proton pump inhibitors.
Right.
And compared it to ones that were not, and they came out and said, we saw a higher incidence of dementia in these people. Now, the medical community has looked at this very carefully, and yes, it clearly is at least a caution, but we have to be careful. When you look at how the study was done, there was a lot of confounding factors that could have been involved, and by no means can we say at this point, you have to stop your proton pump inhibitor because you're going to get dementia. Now, we're going to look at it more, but it comes back to what we talked about earlier, Rick. If it's clearly indicated, I still think the advantages of that medicine outweigh the risk.
I think if you let that acid roll up into that esophagus, you'll end up with destruction of the esophagus.
Exactly.
It's much better to take those medicines if you need them than not if you don't live with it.
So I think the caller, excellent question, and all of us, it raised our eyebrows, and we're looking at it. But right now, it's way too early to just run away from something that's so effective.
When you have dysfunctional brain, that might be the cause of dysfunction of the esophagus, and therefore it's dementia causing esophageal problems, and therefore you're on omeprazole or one of those other drugs. And so who knows which is the chicken and which is the
That's
egg.
correct. And plus, we didn't look at the brains of these people. We know now that there are certain anatomical changes that clearly tell you dementia or not. This was what we call a population-based study. It looked at two groups, but there's so many confounding factors that could interfere.
Right.
So I think be cautious. But if you need that medicine, if I needed that medicine, I would not hesitate, knowing what I know, to continue it right now.
But I would sure try the non-medicinal.
Absolutely.
Woman from Glen, South Dakota. I've not heard of Glen.
Glen, South Dakota?
Do you know where Glen is?
I don't. That's another Ravinia.
Yeah, right.
I don't
You're from
know.
Ravinia.
Yeah.
Woman from Glen, my husband has limb-girdle disease, or limb-girdle muscular dystrophy, and I was wondering if his esophagus would be affected by that.
Possibly.
Yeah.
Possibly.
Well, the skeletal muscle.
We talked earlier about the skeletal muscle.
So let's
erase
explain
here.
that.
So up high here in the esophagus in this region, the upper third is what we usually say. This has what we call skeletal muscle, and that responds to direct nerve innervation there, and there's a coordinated effort. So various muscular diseases that affect the skeletal muscle can affect the coordination of this part of the esophagus. And so, yes, we see this in diseases such as Parkinson's disease.
Oh, yeah, a lot of them will
lot
have
of them.
swallow trouble.
And so this is why it's so important to understand that the esophagus does have muscle. And so different disorders that you would think have absolutely nothing to do with the intestinal tract actually can, particularly if they affect muscle.
All right, we have a question from Sturgis. Someone has corkscrew esophagus.
Corkscrew esophagus.
Same story, that it's kind of like a corkscrew, and it's related to being older. And it doesn't squeeze in that perfect way that you squeeze your toothpaste tube.
It's disjointed. It could
Right.
all be squeezing at the same time, and that can give rise to, boy, I just can't get food down as well. Sometimes I even drink and I have to go slow, or I'll bring it back up.
Right, what do you do for it?
It's
That's the question.
well, it's frustrating. And the first thing I always advise before I jump to any medical trials is simply the way you eat, and recognizing that you have to eat slower, you have to chew your food carefully, and I always advise people to take sips of a beverage, water, whatever it may be,
In between
to
bites.
help it go down.
Take your time.
Now, if that doesn't work, we do have medications that can relax this smooth muscle of the esophagus, but I got to be honest with you, not a huge benefit from that. There's certain amounts of people that will. If it's bad enough, sometimes what I will offer, but this is only after patients say, my quality of life is miserable.
Right.
We can sometimes, when we do an EGD, we will leave a little guide wire into the stomach, and I can take a dilator tube, and it has a hole in the middle of it, and it goes over this wire, and that's there because I can ensure that that dilator goes right where it's supposed to and doesn't go poking a hole in the esophagus. But sometimes doing this dilation, stretching it, and then pulling the dilator and the wire out,
Gives them some benefit.
in selected patients, we can get relief with that. But I only reserve that for the ones that are just miserable and just can't seem to get benefit.
Okay, so we've got not much time, and we've got a ton of questions, so let's just kind of run through them if we
Okay,
can.
I'll try to be quick.
Okay, Nissen surgery, could you explain it very quickly? We
Nissen
did talk about
surgery.
it. Nissen
Fundoplication. Bottom line, there is the stomach here. The problem is that this muscle is too loose. So the surgeon will
Gotta
take
touch
the
it.
stomach and will pull it around and form a barrier. It kind of tightens the esophagus in this location. And what that does is it prevents acid reflux from coming back up. In well-selected patients, and that's the key, in well-selected patients, it can be very effective.
Okay. Someone from Yankton, I've been diagnosed with silent reflux. I have no heartburn, but have phlegm and cough in the morning. I've also lost my singing voice and would love to be able to sing again. Can you touch on this subject? And I think, I know Dr. Reitz, our ears, nose, and throat guy, would, boom, put her right on omeprazole.
If we think, and here's the key, It can be due to reflux, but also there's other conditions, lung conditions that can do this. But the best way that we've learned to understand if this is reflux or not, you can do an EGD, but 90% of the time, it's going to be normal. So the best way we've learned is high dose omeprazole for 3 months. High dose.
40 milligrams.
40 milligrams twice a day even for
Wow.
3 months.
Wow.
If you really want to know if this is due to acid reflux or
The
not.
voice should come back.
If those patients don't respond in 3 months' time, it's highly unlikely, and do not waste your time taking these medicines long term. Look for other things. Sometimes we can put a little probe in the esophagus and measure reflux contents to see if it's truly reflux or not. But we found even that's invasive, and who wants a tube in their nose,
Yeah.
which is what you have to do.
For a day or two or something like that.
If you think it's reflux, a high dose for 3 months, it's safe for 3 months, and then you can determine if in likelihood it's reflux or not.
So this caller said, I have a hernia with left chest that fills my lower lung capacity. I'm 85 and surgery won't be a viable option. She said she has a Bochdalek hernia.
Yes.
What is that?
A Bochdalek hernia. That, yeah.
Bochdalek.
And it's
I've
just
never heard of it.
It's another form
What is
of
that?
a hernia where there can be a big defect in the diaphragm, like in this area, which is her left. So this part of the stomach comes up like so.
Okay.
And, 85, and you're right, sometimes the treatment is worse than the underlying condition.
Just leave it alone.
I would leave it alone. There's just, again, a lot of times patients will learn what they can do and what they can't do. I wish I had a magic answer for that one, but I don't.
That's not eventration of the diaphragm, is it, or is that the same thing?
No, a little bit different.
Okay. Well, and she's having trouble with breathing or oxygen sats and so on and so forth. So it's kind of hard to answer.
It really is.
That's
That's a rock and a hard place. I'm sorry.
She also, does it ever cause constipation, and how would you go about with that? I don't know about constipation.
In general, no. We have seen occasional patients that have a Nissen, and they'll become a little more constipated. We think it might be because one of the nerves that affects the relaxation of the stomach, the vagus nerve that comes down, affects it, and the stomach doesn't have quite as much kick.
Okay.
But the bottom line is it's a stretch, and usually constipation not caused.
You just used enough Miralax.
Right.
77-year-old woman has dysplasia and has had cryosurgery and wants to know if physicians do this in Sioux Falls. So let's talk about chronic reflux and the dysplasia that can occur, and what is the common word for that?
So, Dr. Holm, you talked earlier in the show about when people have long-standing acid reflux up here. What can happen is over time, the cells that line this esophagus change from the standard lining of the esophagus. The same lining of the stomach comes up into here, and that's called a Barrett's esophagus.
So that's Barrett's.
B-A-R-R-E-T-T-S. The significance of Barrett's esophagus, particularly with dysplasia. Now, what she's talking about is, we know that patients with Barrett's have a slight, it's less than we originally thought, but nonetheless real risk of cancer of the esophagus. Most patients with Barrett's do not get cancer. But what we do is we periodically survey this area, and the endoscopist will obtain biopsies from this area of Barrett's. And the pathologists look at it. If you just see Barrett's esophagus but nothing else, you're good, and we'll follow up in 3 to 5 years. Dysplasia means cells are starting to change. They're starting to show us some sign they're not happy. And that potentially can be an early sign that cancer might be brewing. So what the caller is talking about is cryosurgery, which is a freezing probe that you can go down and literally eliminate these cells. You kill them off, and then the thought is that normal esophageal cells will grow in its place. The more common type of therapy is endotherapy, radiofrequency ablation, we call it. It's a high frequency current that also does the same thing. So cryosurgery is one way to treat it. Radiofrequency ablation, or RFA, is the more common. RFA is done in Sioux Falls quite a bit. With cryosurgery, I'm not sure. I have done that, but I'm not sure if anybody else in Sioux Falls is doing it.
How does removal of the gallbladder, this is from Flandreau, removing of the gallbladder affect digestion?
One could ask the question, we have gallbladders for a reason. So,
Right.
so if we remove them, what's going to happen?
Right.
Now, the good news is, most of the time, nothing. What the gallbladder does is, when we eat, the liver stimulates the production of bile. And bile basically helps us absorb food, particularly fat. The gallbladder, basically the bile goes into the gallbladder and it's
20
stored.
seconds.
It gets concentrated. When you eat, it pushes bile into the intestinal tract, aids in digestion. But the majority of people with gallbladder operations do just fine without symptoms. The most common symptom is diarrhea afterward, and we have different ways we can treat it.
Cholestyramine is what
Bile
I
acid binding salts,
Yeah.
and it can usually work.
All right, so we'll talk more. We're right up to the winner of tonight's Prairie Doc quiz question. Tonight, you had to choose the best answer. When reflux of stomach acid up into the lower part of the esophagus happens too often and for too many years, the tissue changes in the esophagus, causing Barrett's esophagus and resulting in more burning symptoms or less burning symptoms. And the answer is, believe it or not, less. It was Susan Schoenfelter from Dimick who answered the question correctly. Thank you, Susan, for participating, and a book will be in the mail to you soon. So let's talk about it. So the funny thing is that the stomach, which is protecting against acid, that tissue grows up into the esophagus and the symptoms get better.
Correct, and think about it. The stomach is designed to withstand acid.
Yeah.
So when you get stomach lining in the esophagus, it withstands the acid, you get less symptoms.
You get better? My problem is going away. But the answer is you may not be. You may be set up for cancer. Yes. So do you recommend that these people get a EGD?
I think that, again, if there's any concern, if you're older, and there's risk factors. We know the people most likely to get Barrett's are male. You and I are in that category. Over age 50, you and I are in that category. Yeah. Truncal obesity, meaning usually if we got the big abdomens, those people are at higher risk. But you know what's interesting?
And smokers.
And smokers. This is one of the rare times where, being a woman, women complain of all the health issues, but it's rare that women will have Barrett's esophagus. So we see it predominantly in men. So those are the risk factors. If you have those and you've never had an EGD and that heartburn's starting to get better, I would, at one time, check it out. If it's gone, you're done. You never have to look again.
All right. We'll be right back after this.
As your baby grows, there are new surprises and adventures every day. With each new milestone, remember, immunizations are safe and one of the best ways to protect against serious diseases, especially between birth and age 5.
Now that my grandson Henry has reached his first birthday and our granddaughter Stella has arrived, we're making sure that they stay on their immunization schedules.
Schedule your children's immunizations today, for baby's sake.
Mr. H came into the office because his wife made him do it. There was a guilty movement to his eyes, although he had the typical non-complaining, modest prairie farmer way about him. He said his heartburn problem was getting worse, particularly at night and when he has a second serving of ice cream before the 10 o'clock news. He admitted he had been chewing a bottle or two of Tums a day for several years, but the problem strangely got better about a year ago until recent weeks. Now solid food like chicken breast wanted to catch on the way down. He admitted he had waited until he got the hay in before coming to the doctor. Well, about 35% of all people have some acid reflux symptoms on a rare occasion, like once a year. But 20%, or about 50 million people in the U.S., suffer from recurring symptoms. They describe half-digested acid food rolling up from the stomach, burning the esophagus, and sometimes into the throat and mouth. Symptoms are generally made worse by big belly obesity, late in the evening food in the gut, caffeine, salt, alcohol, certain arthritis and osteoporosis medicines, tobacco smoke, and sometimes by a stomach infected called H. pylori. And reflux is only made worse, more permanent, and destructive as it continues to occur. The mainstay of therapy starts with avoidance of all those issues listed here, especially less food late in the day. Elevating the head of the bed with books under the bedstead is a powerful and underutilized treatment. Fortunately, there are medicines that can also help. For occasional reflux, over-the-counter Mylanta or Maalox works. And these don't stimulate acid production like Tums, Rolaids, or baking soda does. Fast-acting, as-needed histamine 2 blockers like Ranitidine, the generic version of Zantac, also give quick relief. For persistent symptoms, slower but more powerful proton pump inhibitors, or PPIs, like omeprazole or Prilosec, give a more enduring relief. But please remember, if reflux symptoms are severe enough to require the long-term use of any medicine, talk to your doctor. An underlying infection or a cancer could be the cause. I scheduled Mr. H for an EGD where under anesthesia, a scope was passed down the throat, esophagus, into the stomach and duodenum. We found a cancer in the lower esophagus. Following surgery, radiation, and some chemotherapy, the malignancy has not returned, and that was years ago. Nowadays, when I see him in the clinic, he seems happy to see me, but it's still only after the farm work is done and only because his wife made him do it. A big thank you to our guest, Dr. Tim Ridgway. It's amazing how the doctors of the state are so willing to volunteer to join us each week. It's sincerely appreciated.
Thank you for having me, Rick.
You bet. Now on to our final flu season update. Flu vaccine likely influenced the presentation of the flu this year. Good job for those of you who had the vaccine. You protected not only yourself, but those around you who were susceptible. Now Zika information here. The CDC has raised the level of concern about the mosquito-borne disease as well as the states that may see infestation. So far, all of the cases are in people who have traveled out of the country, but we will probably see isolated outbreaks as the mosquito season progresses. Do not forget to use precautions to reduce your chances of being bitten by a Zika-infected mosquito this summer. We'll be posting some of the suggestions on our website at www.prairiedoc.org. That does it for tonight from all of us here at On Call with the Prairie Doc. Until next time, stay healthy out there, people.
Our bodies are their own chemical plants. We need a significant variety of agents to tell our organs what to do when. Thyroids, diabetes, and your hormones. Next time, On Call with the Prairie Doc.
Hello and welcome to On Call with the Prairie Doc After Hours. We had many great questions submitted beyond what we could do, we could answer during the broadcast portion of our show. So let's get started. 72-year-old woman from Watertown, patient took omeprazole and wants to know if organic apple cider vinegar is an acceptable natural replacement. Have you ever heard of apple cider vinegar?
I actually have. And vinegar is actually, as you know, a weak acid. But I have heard reports that patients will get symptomatic relief with agents such as that. So with the natural ingredients, I always tell people don't go and invest the farm on them, but give them a try, and they're safe. And if you find them effective, great.
Now, you talked about peppermint or spearmint. I've heard spearmint used for upper GI symptoms. What do you know about that?
Well, we talked about peppermint relaxing the lower sphincter muscle, but in proper doses of spearmint, yes. And more than reflux, it's just soothing. It's soothing to the stomach. So the indigestion in the graphic you put up earlier, it can definitely help to settle down an upset stomach. If you
But if there's reflux, it'll make it worse.
Be careful, yeah.
Caller has a problem with esophagus that seems to be inherited, as his father had a similar problem. Is that an inheritance thing that you?
It can be. There's something called the Schottky's ring, which is a benign stricture at the lower GE junction, the esophageal gastric junction. And yes, we've had case reports of that. Dilate them, they usually do fine.
Okay. Well, this gentleman, he has had his esophagus stretched 3 times.
Yep.
Sometimes he cannot swallow food and has to bring it back up. Is there something? You see this often. Is there a name for it? And you just explained that, didn't you?
Yeah, we do. And one of the things, if you're needing to get this stretched repeatedly, many times there's an underlying reason, such as acid reflux, that's not being controlled enough. So
maybe double your omeprazole.
Try to get up on that, and sometimes that'll lengthen the amount of time in between you need to have your esophagus stretched.
Elevate the head of your bed.
And do all those lifestyle things.
Small, frequent
but
eating.
Important.
Can stress cause ulcers? That's the big thing. We used to think stress was the cause.
Remember the days when tranquilizers used to be given and people were putting on bland diets? And I was just talking to a group of students about this the other day. The answer is absolutely not. They may make you more sensitive to the symptoms of an ulcer, but they don't cause an ulcer. We know in 2016, 2 main causes, that bacteria you mentioned on the show, H. pylori, and non-steroidal drugs such as ibuprofen, Aleve, Advil, those kind of medicines. Those 2 things will cause over 95% of ulcers we see in the United States.
So, and H. pylori, we didn't cover it earlier. Let's just say a quick word about it. Can you treat it? Can it cure it?
H. pylori is a little bacteria that harbors in the stomach. It is a known cause of duodenal and gastric ulcers. And we know that if you just treat with acid blockers and stop them, the ulcer can come back in a lot of instances. You eradicate H. pylori with triple therapy, antibiotics, and a proton pump inhibitor for 2 weeks, you can eradicate H. pylori and not have recurrence of the ulcer.
But you've got to have that. Those are prescription medicines. You can't do that.
Absolutely. You got to make sure you do it right, and you also got to make sure you check to make sure the bug is eradicated.
Right. I had a patient who had iron deficiency anemia. I checked his stool for blood. It was just negative trace. I had a patient do an EGD, or a doctor do an EGD, and they didn't find much, but they biopsied a bunch of different sites, and it came back celiac disease in the small intestine. Isn't that an amazing thing?
I have a standing order in my endoscopy unit now. Anybody that endoscopy sees for iron deficiency anemia and they don't see an obvious cause, you biopsy the duodenum to rule out celiac disease.
20-year-old man from Rapid City. He's had a peanut butter consistent type stool since having an appendectomy 2 years ago. Stomach cramps are not uncommon, and he notices coffee and any amount of alcohol really worsens the diarrhea. It's recently gotten worse. Any ideas that could be causing this?
Well, I can say that in all likelihood, the appendectomy did not cause it.
It wasn't the appendectomy.
Doesn't have effect on the GI tract, so I think that was coincidental. I think make certain that your doctor has checked you out for all the other things. There's something just called functional dyspepsia or an irritable bowel syndrome that can create these things, but you want to make sure you've ruled out other possibilities. So I would revisit the doctor.
Celiac disease, as well as ulcers and reflux.
Inflammatory bowel disease.
H. pylori.
H. pylori, there's all those things.
Crohn's disease.
So you just need to really have a careful history and physical done, do some investigation, and then go from there.
Wonderful answer. 58-year-old woman from Sioux Falls. Patient has severe esophageal spasms. Wants to know if acid reflux is the cause of it and what can be done to help this out. Sometimes those spasms, like crushing substernal chest pain radiating to the neck down the arm,
mimic a heart attack.
Perfect heart attack picture.
Absolutely.
But it isn't. It's spasms. Why does it occur, and what can you do?
Well, acid reflux is one cause, but it's not a common cause of spasms. And sometimes it's called diffuse esophageal spasm. It's a condition. Now, what we'll use, believe it or not, in those instances, nitroglycerin, which you'd think is for the heart, but how does it work? It relaxes the muscle of the vessels of the heart. It also relaxes that same muscle of the esophagus and helps prevent spasm. Calcium channel blockers also have been used in this instance.
Like verapamil,
diltiazem, and they can be effective as well. I'd give them a try.
We didn't touch on eosinophilic esophagitis, and we should say a word about that.
Yes, it's something that we're recognizing more and more. Most predominantly affects young males. So, you know, when we see young males come in with this dysphagia, and we may not see a stricture or a cancer or a blockage of the esophagus, but the esophagus will be ringed. It'll have a ring-like effect to it. And that's the hint that it may be eosinophilic. We think it could be a food allergy, and so we always have patients tested for food allergies. Some people will respond to just a proton pump inhibitor, but some we need to do an elimination diet if we find a true allergy. The point is, it is treatable, but you have to recognize what it is and then deal with it.
Topical steroids, inhale.
Topical steroids are very good. So that's the other option, budesonide. And it's the budesonide that you used to inhale for your lungs. We tell people don't inhale it, swallow it. 2 puffs twice a day, and it coats the esophagus and can help immensely.
Man from Brookings, what's the difference between an ulcer of the stomach and of the intestine?
Yeah, it's a good question, because I ask my students that all the time. First of all, they're the 2 most common locations, the duodenum and the stomach. What is the difference? They basically look the same. There's one key difference. If you find an ulcer in the stomach, you have to absolutely be sure it's not cancer, because cancers of the stomach will sometimes present as an ulcer. We always biopsy stomach ulcers. We don't biopsy duodenal ulcers because they are benign. But other than that, they're basically the same thing. You treat them the same way.
And what percentage of those people who have duodenal ulcers, the old classic have H. pylori as a source?
Well, it depends on what part of the country you live, but actually we think now 80 to 90%. I mean,
80 or 90%?
Most people will have H. pylori, although I will still see occasional ones that do not.
What about stomach ulcers? Sometimes H. pylori or
Sometimes
not?
H. pylori, but more commonly ibuprofen, Aleve, Advil, those kind of medicines we talked about.
Does H. pylori ever cause reflux?
That is controversial. Right now, the issue is it's not an indication to check for H. pylori if they just have reflux. On the other hand, we've learned if you treat H. pylori in patients that have H. pylori in the gastric antrum, which is the lower part of the stomach, they can benefit from reflux. But if the H. pylori causes the proximal stomach to become inflamed and whatever, sometimes you treat it and it actually can get worse. So it's kind of a hit and
Kind of
miss.
a hard answer.
It's a very difficult one.
We've got a question that's maybe we don't have great answers. I think I may be suffering from a hernia. I'm not quite sure. The affected area is very tender. It feels bulged. I don't want to go to the doctor if I don't have to. Is there any way to confirm this as a hernia?
Well,
That's different than hiatal hernia.
It's different than hiatal hernia.
Abdominal wall hernia.
Abdominal wall hernia, inguinal, in the inguinal region or the femoral region. And you know, if this person has distension and it's tender, I don't know about you, Rick, but I'd want it checked out, because you want to make sure if a loop of bowel gets trapped in there and then you can get dead tissue, it can be a real problem. I would advise have it checked out. If you've got bulging and it's painful, I would check it out.
And if it's not painful, I'd probably leave it.
Leave it alone. You can, and if you can push it back in easily, leave it alone. But if it's tender, painful, red, get it looked at.
For a guy who's had 2 inguinal hernias, I waited until they got painful.
Absolutely. You
That's
wait
what
for
it-
symptoms.
Yeah. 84-year-old man from Edgerton, Minnesota, diagnosed with tracheobronchial malacia. Is there anything to be done about this constant cough?
Those are difficult. That's in the realm more of a pulmonologist than with me. I do know that they're looking at new ways of dealing with it mechanically, but
It's a tough area.
I can't go beyond that.
Because it collapses.
It's
and
very
it's tough.
difficult.
Yeah. And that might be, I think that's our last question. I really appreciate you
Thank
coming.
you.
And
We
thank
covered
you
a lot of questions.
We did, didn't we?
Yeah, thank you.
And thank you for joining us on our website. We appreciate all of your questions and the opportunity to answer them. So until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.
Funding for On Call with Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
The South Dakota Foundation for Medical Care, an organization working with the state's healthcare community to improve quality and care as a part of the Great Plains Quality Innovation Network.
Additional funding is provided by Aberdeen Asthma and Allergy.
Avera Heart Hospital,
Brookings Health System,
Dakota Allergy and Asthma,
Dakota Care,
Orthopedic Institute,
Physicians Care Sanford Clinic Community Service Committee,
the South Dakota State Medical Association,
Swiftel Communications,
and Vance Thompson Vision.
Closed captioning for On Call with Prairie Doc is provided by
Avera,
Brookings Health System,
and Fishback Financial Corporation.